my name is Jalen Avila. Now, I haven't done an arrest and peri-arrest ultrasound lecture in quite a bit of time, honestly. And I wanted to share this lecture with you all that I gave a few weeks ago at the Navy residency in Balboa here in San Diego. Amazing group. Shout out to all of you. Thanks for having me. You guys were amazing and had amazing questions, which is one of the reasons I like teaching and lecturing, especially to residents, is because I get asked questions that I've never really thought about, and it helps me think about different ways to approach problems. It's all amazing. I'm very thankful. And now I'm going to share that lecture with you all. So I like to think about arrest and peri-arrest ultrasound kind of as a group, because if you have a patient that is peri-arrest, I often would recommend approaching that patient similarly to how you would in a patient that is arresting. So I think about this in kind of three big categories, which is identifying reversible causes, pulse checks, and procedural. Now, regarding identifying reversible causes, this kind of goes along to that H's and T's, which is just a horrible mnemonic. I never remember what the H's and T's are, but if you happen to be one of those people that can actually think about it and remember it, these are H's and T's out of that list. It's about half of them that ultrasound actually does really well at. And it's even the gold standard as far as bedside tests for quite a few of them, if not all of these five here. Now, this is going to be a brief review. If you want a more in-depth video on how to differentiate tamponade from pericardial effusion, check out that video. But here we have on the left side of the screen, we have a heart not in tamponade. And then on the right side of the screen, we have a heart that is in tamponade. There's a big circumferential hypoechoic effusion going all the way around. And if we happen to freeze this clip here, we can see that the mitral valve, when it is open, we're seeing a dip of that right ventricular wall right here. So mitral valve is open and this RV free wall is dipping. When the mitral valve is open, we can assume that the tricuspid valve is open diastole. And tamponade is when we see the right ventricle collapse when it's supposed to be filling, diastolic collapse. And so if we see the collapse when we have the valve open, that is diastolic collapse, tamponade. Although that being said, if I have a peri-arrest or an arresting patient and I see a moderate or large pericardial effusion, I'm going to assume that that is at least a component of what's going on, and I'm going to attempt to aggressively treat that with a pericardiocentesis. Next is going to be hypovolemia versus no hypovolemia. This one's a bit, it's kind of useful. If you have a very hyperdynamic heart, a very vigorous moving heart with a good ejection fraction like we see on the right, that with a collapsing super small IVC, I'm going to assume that the patient could at least tolerate fluids. If I see a patient that doesn't have this very thirsty looking heart and they also have an IVC that is normal or enlarged, I'm going to assume that fluids might not help this patient, although this is something that I'm very happy to give at least a 500 cc bolus to see if it helps, unless I have a direct contraindication for it that I'm able to identify. Next up, we're going to talk about a tension pneumothorax. Now, typically we think about this as sliding versus no sliding, and we're definitely seeing sliding on the left right here and no sliding of that pleura on the right. Now, I will say if I have a peri-arresting patient and I don't see sliding on one side, I'm much more likely to think that maybe there's pneumothorax as a component of why the patient is hemodynamically unstable. Now, that being said, you have to keep in mind that the absence of lung sliding has to be taken within the clinical context. For instance, if a patient is not breathing and doesn't have a pulse, their lungs are not going to move. So if you don't see lung sliding on both sides on a patient that's completely apneic without a pulse, I wouldn't necessarily assume that that's a pneumothorax. I would use this as a tool in my assessment of the patient to try and figure out what's going on. Now, lung sliding definitely rules out a significant pneumothorax, especially in the area that it's being evaluated. We typically think about a lung point, which is where we see the no lung sliding on one side of the screen and then sliding on the other side of the screen. So we see lung sliding, no lung sliding on the same image. And what we're seeing there is we're seeing basically the limit of the pneumothorax. Remember, you have the parietal pleura, which is basically the underside of the rib cage. Then you have the visceral pleura, which is the lung skin, the outer covering of the lung itself. And when you see sliding, you're seeing the visceral pleura attached to the parietal pleura. That's why you can see the sliding. And if you don't see sliding, it's because there's a separation. There's air between the parietal pleura and the visceral pleura. And if you have a place where you can see the border of that pneumothorax, that's when you see a lung point. That being said, if you have a patient with a tension pneumothorax, you're actually not going to see a lung point because the lung's going to be like a little tiny like nub in the hilum. And so there's going to be no part of the visceral pleura that's touching the parietal pleura. So when we're thinking about a tension pneumothorax, it's clinical context, and we can look for these things. So definitely the absence of lung sliding. We'll see a shifting heart. So let's say it's a left-sided absence of lung sliding. And then you see a great peristernal long axis view, but on the right side of the sternum. And that is, of course, assuming that they don't have like dextrocardia or situs inversus or something, and a plump IVC. All of those things would lead you towards possibly the patient having a tension pneumothorax. That being said, if I have a patient and I'm doing chest compressions and actually see lung sliding on one side and don't see lung sliding on the other side, I'm doing a finger thoracostomy in those patients because it's very likely at least a component of what's causing your patient's hemodynamic instability. I'm going to take a brief pause here just to let you know that all of our content is on the coreultrasound.com website. That is ultrasound podcast, 5 minutes sono, ultrasound of the week, clip bank, and we also have our courses page where we have the core ultrasound fundamentals and core ultrasound question bank where you have 3,200 questions with feedback, including narrated videos explaining the question. Check it out and back to your video. Next, let's talk about thrombosis. And there's a couple in this category. One of them is a MI, a myocardial infarction. And we look for regional wall motion abnormalities, or RWMAs. And you can see here, this is thanks to Ben Smith he either did these or taught me how to do these overlays of colors. And you can see here that there's essentially 3 main coronary arteries that go to the heart, and you can actually figure out what is the distribution of the ischemic artery based on what part of the heart is contracting normally and what part of the heart isn't. Now, this is important because when you have an arresting patient or a peri-arresting patient, it's like difficult to like put all the stickers on and hook up the machine and then like put in the patient info and then tell everybody to like, hey, sit still, tell the patient to stop breathing so vigorously, like calm down with the breathing. I know you're about to arrest, but be careful with the breathing. And then wait for the wobbly lead to fix and then get the EKG. This is hard to do in a critical situation, which is why the ultrasound is useful, even though the gold standard is a cath, an angiocath, or it is the EKG. Sometimes you just can't get that stuff right away. And this is why this is helpful. And there is some evidence that you'll actually see these regional wall motion abnormalities prior to the definitive ST elevations that you might see and often see on an EKG. So we have our kind of guide on the left side of the screen. And now let's look on the right. Where is that regional wall motion abnormality? Now, what we're looking for is not movement per se. What we're looking for is contraction. So is the wall getting thicker and thinner, or thinner and thicker? There you go. So if we look over here in the septum, we're seeing pretty good contraction, change in size of that muscle. Whereas if we look over here, we're definitely seeing a little bit of motion, but the diameter of this muscle right here is not changing. So we're having movement, but we're having no changes of the width of that muscle, which is what a regional wall motion abnormality is. This patient had a circumflex artery occlusion. Here's another one. This is an apical 4-chamber view. Now, this one had a very dramatic EKG when I did it, but we can see very easily here the regional wall motion abnormality. We can see here that the right heart is actually contracting quite well. We see the septum right here contracting pretty well. This lateral wall, which is a circumflex, contracting well. But if we look here, right, this area right here, we're not seeing good change in diameter of that wall. This is an LAD lesion that we're able to see on this apical 4-chamber view based on this regional wall motion abnormality. And then over here, this is a RVMI. Basically, the entire right ventricle is the right coronary artery in many patients, not most. We can see here that this is a patient without a pulmonary embolism, and we can see here a very enlarged right heart. We see no McConnell sign, which we typically see, at least in the emergency department, with an acute PE. And we're probably, it's off the screen because this RV is so enlarged relative to the LV. I couldn't get it all into one screen, and I wanted to get the lateral wall here. You can see here how the circumflex contracting well, septum, not so much. And over here, not so much either. This was actually multi-vessel disease. This was right coronary artery as well as LAD, which you definitely can have more than one blood vessel be the problem in your patients. This is the other thrombosis. This is a pulmonary embolism. We have our normal on the left side over here. Now, this is an apical 4-chamber view. You can look for right heart enlargement on really any view, but this is the one that we typically teach, this apical 4-chamber. We have our left side of the heart over here. This is the ventricle. This is the atrium, mitral valve. Right here, we have the tricuspid valve, right atrium, right ventricle. And if we look at the width just underneath the tricuspid valve compared to the mitral valve, so looking at the ratio between the LV and the RV, LV is bigger. This is how it normally is. If we look over here, we're seeing this right heart is bigger than this left heart over here. You have RV enlargement plus I'm seeing something called the McConnell sign, which is hyperkinesis of the RV apex right here. You see how bouncy that top part is relative to that more hypokinetic lateral wall? This is called the McConnell sign. And in the emergency department setting, if you see this, it's highly specific for a pulmonary embolism. We're talking mid to high 90s. Now, I definitely want to keep in mind that you can have a PE without obvious right heart enlargement. We have over here, so it's normal over here. We have the left heart over here, right heart over here. I'm not seeing RV enlargement over here. The RV is appropriately sized relative to the LV, but look at this guy right here. That is actually a clot in transit. I'm actually seeing the PE try to get into the lungs. Even in the absence of right heart enlargement, your patient can still have a PE. Don't forget that. And then, of course, remember that even during active chest compressions, you can look for a DVT. We have the absence of a deep venous thrombosis over here, and then we have the presence of a DVT over here. We can see this hyperechoic clot as well as the inability to compress. Those are two findings of a DVT. If you have a patient that is acutely decompensating or they've arrested and you see this, this might actually push you towards pushing thrombolytics, even if you are unable to get a good heart view or you don't know exactly what's going on. Remember, a tool in your arsenal, not something that we should be using in isolation, but oftentimes the key to help best manage your patients. Next is going to be trauma. So we know about the FAST exam. If a patient comes in and they're exsanguinating, like there's blood from a severed femoral artery and they're just spurting blood everywhere, we know where that's from, right? That is blood loss externally. Remember, you can also have internal blood loss from internal trauma. So we think about that. Typically, our history is going to help us know if it's trauma or not. And also remember that patients can have a positive FAST exam, and FAST exam in quotes because FAST exam stands for Focused Assessment of Sonography in Trauma, but you can use the same views to look for any cause of fluid in the belly. To be honest, the time that I use it the most is when I'm looking for ascites. That's actually when I use the FAST exam the most, is to identify free fluid due to portal hypertension. You can also see in the setting of a ruptured ectopic, a ruptured bowel, and a ruptured AAA. All of those things can cause a positive FAST in a hemodynamically unstable or crashing or a resting patient. I will say that if a AAA ruptures into the peritoneum, which is where the FAST exam typically looks for fluid, Oftentimes they don't make it to your emergency department, unfortunately, because the quantity that they lose is so high and so fast, and it's hard to replenish it. But sometimes you'll see it. Sometimes they'll have a focal, very small leakage. Sometimes it'll leak into the retroperitoneum, which is a lot less space in the retroperitoneum. And sometimes it will kind of leak into the peritoneum, where you'll see it on the similar views that you would with that traditional FAST. So a brief review here of the FAST exam. We have normal on the left. We have hypoechoic free fluid on the right. A little reminder to not just look at Morrison's pouch, because for this one specifically, if we just looked at Morrison's pouch and we didn't look over here, we would actually say that this was negative. But we have to look at the inferior pole of the kidney, caudal tip of the liver, and there is where we see that free fluid. And this is actually where fluid will accumulate first, and then it'll go up into Morrison's pouch. We have a pelvic view. For the FAST exam, I always have the probe marker facing up. So if I am looking at the right upper quadrant or left upper quadrant, I'm in a coronal plane with the probe marker up. And if I'm in the pelvis, I am in a sagittal orientation. When I look in transverse, it confuses me more than anything. I always have to confirm it in the sagittal orientation if I see something on the transverse, because sometimes you can see something and it's actually seminal vesicles or it's some other structure that is not intraperitoneal. Whereas in the sagittal orientation, as long as you do a good sweep and look side to side, you can easily see that this communicates with the peritoneum. Small bit of free fluid here. This was an ectopic pregnancy. And over here, we are not seeing any significant free fluid. And then the hardest view, which is also the least likely to be positive in isolation, is the left upper quadrant view. Remember, the left upper quadrant is not a mirror image of the right upper quadrant. They look kind of similar, but we have to look in slightly different places. For the left upper quadrant, we want to look suprasplenic. Remember, the head's over here, the feet's over here, anterior abdominal wall and back. The patient's laying on their back down this way. This is negative. And then right here, we're seeing that free fluid surrounding that spleen. Now, even though this is the least likely to be positive in isolation, it's a good idea to look at all three views just to make sure. That being said, the likelihood of your patient being hemodynamically unstable due to blood, let's say, in the peritoneum without a positive right upper quadrant or pelvic view is super low. Like usually they have it everywhere if they've lost that much blood. Because remember, you can lose about 20% of your volume before you start to show hemodynamic compromise. And if you look at the preponderance of the data, it takes about 300 cc's or so. It's about a Coke can or a sparkling water brand, generic can of blood in the peritoneum for you to consistently be able to pick it up. So usually by the time you've lost this amount of blood, you're compensated. You're probably a little bit tachycardic, but your blood pressure is either normal or even slightly elevated because of your increased adrenal tone, your increased catecholamines. And if you're hemodynamically unstable from blood loss, it's usually a large amount, meaning it's probably not going to be in isolation in the left upper quadrant. So I start with the right upper quadrant pelvis, and occasionally I'll go into the left upper quadrant if I think that honestly it might be sepsis that's causing these symptoms, because I have seen isolated free fluid in the left upper quadrant from really bad pancreatitis in the setting of just an isolated left upper quadrant in a patient that is hypotensive and tachycardic. Now, the next part that I want to talk about is the procedural component. This is probably the most important one, is a pericardiocentesis. This is a nice little simulator. You can definitely go subcostal, but go wherever you can see the biggest pocket and it's the most shallow depth from the skin surface. You'd be surprised how often that's going to be peristernal or that's going to be apical. Remember, if you can see the pericardial effusion and you see it throughout the whole screen, there's no air or lung in between the skin and that effusion. So you're actually safe to go there, because if you can see the effusion, it means there's no lung between the two, at least not aerated lung. And so it's a safe place to do it there, and definitely do it under ultrasound guidance. If you are in the peristernal or the apical, please use the linear transducer or the curvilinear transducer instead of the phased array because you'll be able to see the needle so much easier. In codes, I actually often find myself reaching for that portable ultrasound to do those crash fem lines if we don't have access. It is kind of an extra step and it's not a full sterile, just like any crash line isn't fully sterile. I've found that overall, it's a lot easier to do these central lines, even in a crashing coding patient with ultrasound guidance, because you're just able to approach it so much more accurately, no redirections, and you're not going to accidentally poke the artery or the bladder instead of the vein. You're definitely going to be less likely when you use that ultrasound. The other kind of unlock, and this is of course assuming that you have other people helping you in that resuscitation, is whenever I can, I try to place an arterial line, and this is to help when we're not sure if there's a pulse or not. We don't really need to do a pulse check where someone feels the pulse if we have a good art line, because if we have a good art line, we have a pressure in the art line, diastolic should be better than about 40, 35 to 40. And if we have that, it's likely a perfusing pressure to the heart and to the brain. Obviously, you want a normal blood pressure, but that's kind of minimum. Now, in the next section, I'm going to talk about how I use ultrasound in pulse checks. Now, us humans, even though our fingers have really good sensation, we do notoriously bad at detecting the pulse. This is a study, it's a bit older, but it was a great study. It was patients that were either on or off bypass. So it was a really good gold standard of if they had a pulse or not. They had 207 EMTs that evaluated 16 patients, and they had no time constraints. They're just like, tell us if there's a pulse or not. 10% of the time, the providers thought there was a pulse when there wasn't. 45%, they thought there wasn't a pulse when there was a pulse. And the average time it took to make those incorrect assumptions or decisions or choices was 24 seconds, which is much more than the 10 seconds of a pulse check. And only 17% answered the question correctly within that 10 seconds. We need something else. Now, I will say that an R-line is really my gold standard, but I often find myself using that ultrasound if I'm not sure. And I do have a very specific way that I do this, and I'll explain it in a couple of slides. But let's talk about how to identify rhythms and what they look like. So right here we have a heart, and let's say that somebody states that they feel a pulse. They do not feel a pulse, right? They're feeling their own pulse. This is a PEA standstill. We see a little bit of movement here of this mitral valve on this peritoneal long axis view, but even though there's like an ejection fraction of like 1/4, like 0.25% of an ejection fraction, it's definitely not perfusing. I treat this the same as standstill, which is basically resume compressions. Now, when I see this, I don't need to wait a full 10 seconds of this. I'm seeing that the heart has electrical activity without a pulse, and I'm seeing that this EF is so incredibly low. I am gonna, as soon as I see this, I wait about 6 seconds, and I'm resuming compressions at this point, going down my ACLS algorithm. Now, what about this one? We're seeing the ventricles kind of doing its own thing. It's fairly regular with how it's beating, right? It's regular. This is what ventricular tachycardia looks like. What do you think about this one? Not a lot of movement, right? We are seeing a little bit of movement, almost like waviness. Let's say fluttering. Let's say fibrillation of that mitral valve, a little bit here of that posterior wall. This is fine VFib. This gets a unsynchronized or non-synchronized shock. Here's another example of ventricular fibrillation. We're seeing the bubbles here of the medications we're giving and the bit of blood kind of smoke that we see when patients don't have good forward flow. The blood starts to get a little soupier, and we're seeing that kind of jiggle a bit. This is also fine VFib. Now, what about this one? This is a very vigorous ejection fraction. This is one that if somebody says they don't feel a pulse, I'm going to be very skeptical of them being accurate, because this is a really good ejection fraction. This is assuming the patient has been given some fluids and assuming you don't have another reason why such a hyperdynamic heart with a definitely higher than 50% ejection fraction might not have a pulse. And remember, we're not that accurate in these patients for detecting pulses. So this is, again, a tool to help you figure out what to do with your patient. Here's another one here. This one, there's definitely some movement, but this is PEA. I mean, the movement is so small that even if this kind of rhythmic motion were intrinsically from the heart, it would still be too low of an EF for me to do anything and to treat it anything differently than PEA standstill. What we're seeing here is we're actually seeing the effect of bagging. When we have a good endotracheal tube and we're pushing big volumes, the heart is going to shift a bit and it might look like some cardiac motion when in fact, it's just essentially a bystander to what's happening into the intrathoracic pressure and due to bagging. Now, what about this one? Now, this one is an ejection fraction is very low. I'd say like an EF of like 15% maybe. Now, it's hard to know if this is a perfusing rhythm on a patient. I would kind of assume not. But here's the thing. Some people walk around with an EF of 15, 20, and they're relatively functional. So if I have this situation, I'm going to take it with a grain of salt and try and make sure that I feel or not feel a pulse. But really the big thing here is that art line. Having an art line will dramatically help you know if that's perfusing or not. Look at the pressures, look at actually waveforms. You can look at arterial waveforms with that art line to help figure out what to do. Now, next, I want to talk about the kind of, let's call it the black sheep of the family, and that is this POCUS and pulse check delays, which when it was first kind of noted, I was really kind of disappointed and sad about it. And listen, if data is there, I will believe the data. And this is showing that there is an association with pulse checks. In these two studies from 2017, there's an association when ultrasound is used of prolonging the pulse checks. And what I'm going to do is I'm going to actually stop there. Obviously, this is something that I don't believe is accurate, and I believe that there's reasons why this showed up in these studies. But we've been going for close to 30 minutes. We are going to do part 2 where I talk about this and basically the conclusion of my talk in the next episode. Don't forget to check out courses.coreultrasound.com, ultrasoundleadershipacademy.com, soundandsurf.com. Our conference is coming up in November. We are sold out for in-person, but we are still selling virtual passes where we'll give you access to the recorded content about a week or two after it, because I have to, record it and do all the editing and all that stuff, put it on the website. So it'll be a little bit, but you'll still have access to it. I hope to hear from you soon, and happy scanning.